Hello, everyone. My name is Dr. Al Brundio, and I am the lead person on a grant that we have that is administered by the American Academy of Addiction Psychiatry. The International Nurses Society on Addictions is one of the organizations that's part of this grant program, which provides us with the funds to do clinical training for nurses and, of course, any other type of healthcare provider as well. So it gives me great pleasure tonight to introduce Suzanne Kinkle. Suzanne is a certified addictions registered nurse. Currently, she is the director of what is known as the RAMP program in New Jersey, and that is the Recovering and Monitoring Program. This program is administered by the Institute for Nursing within the New Jersey State Nurses Association and reports to the Board of Nursing in New Jersey. And Suzanne tonight will be sharing with us peer assistance and opioid dependency. Now, a little more information on what will happen tonight. Suzanne will present the information probably for about 20 to 30 minutes. Then we're going to do a case study, and I'm going to present a real case that I experienced as a chief nursing officer of an acute care hospital, and we'll process the case study, and then we will open it for questions and answers for about the last 15 minutes or so of this hour-long presentation. There will be 2 surveys that you will complete following the program. One will be emailed to you shortly after the program, and then we will do a 30-day follow-up survey. We really appreciate you taking the time to complete the survey, as again, this is required in the grant program. And if you are a nurse, you will be receiving 1 contact hour of nursing education. This has been approved, and those contact hours are provided by the California Board of Nursing. So without further ado, I want to give a warm welcome to Suzanne Kinkle.
Thanks, Al. How do I move this along? Al, I don't know how to move it along. Al, can you hear me?
Yep, I can hear you.
Okay, how do I, it's not moving along.
Just hit your escape button and see if you can pull out of the slideshow, and then see if you can start it again.
Yeah, it should move when you...
Okay.
There you go.
Okay, so these are the required slides that we need to show as part of the grant. Audience. These are the objectives. Okay, so I'm just going to start with what is addiction. Today there's still some controversy over whether or not addiction is a disease. The American Society of Addiction Medicine defines addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. The American Medical Association has also recognized addiction as a disease since 1956. And this gives credibility to the fact that addiction is not a moral weakness, or people who suffer are horrible or bad people. And because addiction is recognized as a disease, this also allows for insurance companies to pay for treatment, and patients are able to seek temporary disability while in treatment, and allows employers to allow for medical leave of absence while patients seek treatment. The key characteristics of the disease is compulsion, lack of control, and continued use despite devastating consequences. And addiction is just like any other chronic disease that involves cycles of relapse and remission. There's no cure, but it is treatable. And without treatment or engagement in recovery activities, addiction is progressive and can result in death or disability. So why nurses? Why nurses different? Yes and no, or no and yes. Okay, the ANA estimates that 6 to 8% of nurses have a substance use disorder that impairs their practice, while others report it to be as high as 10 to 15%, which is the same as the general population. So basically about 1 in 10 of nurses may may be impaired or be in recovery from alcohol or drug addiction. But nurses are reported less frequently because of their professional roles. Most think that the disease of addiction does not affect nurses because they're educated, they know better, and they're taking care of patients. However, it does, and the results are the same as any other chronic disease if not treated. It results in death. Nurses, but unlike the general population of occupational hazards, nurses have access to medication because of the profession. And because we care for patients, intervention is required. The sooner the better for the protection of the patients, but also for the nurse. Anytime a nurse is suspected of having a substance use disorder, patient safety is the #1 priority. And because of the accessibility related to the job, special monitoring is required. Some of the risk factors for nurses are slightly different. Nurses are at higher risk for impairment than the general population because of their profession. Nurses are educated about medications, their actions, and they see the benefits patients derive from being medicated. The negative connotation of using pain medication is somewhat diminished because of their education. And also because of their education on medication, nurses tend to self-diagnose and self-medicate. Lack of education on substance use disorder also contributes to the negative stereotyping and stigma. Nurses, along with most, have a negative attitude towards addiction. So most never think it can happen to them, nor do they feel they fit the stereotypical look of an addict. The ones we see on TV, they're show famous people at their worst while active in their addiction. So nurses don't feel that they look like those people. They also feel that sometimes that they're homeless, living on the streets. But most nurses, when they're caught, they have homes, they have jobs, they have families, etc. The nursing environment also allows for accessibility to a variety of medications, including narcotics. Besides pharmacists and physicians, no other profession has medications at their fingertips. The accessibility contributes to this also contributes to diminishing the negative connotation of using pain medication. And nurses also have access to physicians who they work with. They build relationships with physicians. They can ask physicians as their friends to give them something for their back. They can ask one physician on one shift, one physician on another shift. So they have a lot of access to getting prescriptions. The stress. The role strain in the hospital creates stress, increases the risk for impairment. The higher workloads, the higher patient acuity. Nursing can be both physically and emotionally draining on a day-to-day basis. Nurses see patients die, and some units it's a common occurrence. Additional risk factors for nurses include disrupted sleep patterns because of rotating shifts, and overtime and accessibility of medications all contribute to the nurse at a higher risk to take medication, sometimes to fall asleep or to stay awake because of the shift work. Lack of education on substance use disorder in hospitals and organizations and schools of nursing leads to unawareness of the signs and symptoms of the disease. This contributes to nurses being unprepared to address the problem. One of the contributing factors is that behavior is often overlooked and enabled by their coworkers because they've not been identified. Which leads to denial. Denial is a symptom of the disease for the nurse, but denial is also part of the enabling of the coworkers of the impaired nurse. Anytime a nurse is referred to the New Jersey RAMP program, it's really never a surprise to coworkers, because most have noticed the nurse impaired with someone off, his or her appearance, looked a little disheveled, or thought they may have smelled alcohol, but most tended to ignore it. They thought that it might be wrong. They thought, that if they hoped it would go away or they would get better. Lack of education, again, contributes to negative stereotyping. Our society has stigmatized the disease of addiction that no one wants to admit they have a problem. Nurses continue to be rated the most honest and ethical profession, higher than doctors and pharmacists. So the shame and guilt for them is high. The shame is an emotion that the majority, if not all, feel when they have a substance use disorder. The shame is so tremendous that it almost paralyzes some nurses and prevents them from seeking help. Also, the intense shame. Some nurses have reported thoughts of suicide as the way they handle the situation. That's frightening for us in RAMP that we have nurses that sometimes feel so ashamed and so guilt that, their thoughts of suicide is high. Also, for many, their identity is being tied to a nurse. And if they admit they have a problem, they're fearful that they'll lose their identity. The other thing about education, too, nurses are not taught what to look for, or the risk factors for nurses, or that addiction does happen to nurses while they're in school. It's not a topic that's really discussed. Some of the risk factors for nurses are also barriers to treatment. The majority of nurses today are women. 90% are women, and while societal stigma placed on individuals with the disease of addiction exists for all, it's even higher for women. Women are held to a higher moral standard than men, and they are seen as also the primary caretakers of children. So a woman who is the mother is looked poorly upon, but not only for being a mother, but also for being a nurse. And as nurses, we're the caring profession, and we often have difficulty asking for help from others. And we also see ourselves as different. Sometimes we talk about this with the majority of nurses around. They never thought it could happen to them because they know better. They see themselves different. They don't see themselves as the person that comes into the ER, which they call drug seeking. They don't see themselves as that person. And a huge barrier for many of the nurses is the financial concern. Many are terminated when they are caught diverting, and therefore the loss of the insurance, they can't afford treatment. And sometimes when they do have insurance, they have high deductibles and copays that they can't afford. Fortunately for New Jersey, we have county funding every one of our counties, so nurses are able to access treatment. And we also have providers in our region that will pay for COBRA for our nurses and will also help them with payment plans so that they can access treatment. Another barrier to the nurse getting help is enabling of coworkers. This is common as coworkers usually develop friendships, and this can cause blinders and cause the friends not to see what is happening, or to make excuses for the nurse. It can also cause others to accept the nurse's responsibilities and duties. Some will ignore it. Others hope that it'll get better. Some will minimize it and make excuses for the nurse, such as they're going through a divorce, the parents are sick. Sometimes others will lie for fear that he or she will lose their job, the nurse will lose their job. And others don't want to be the whistleblower on another nurse who may have a problem. But the more that you accept the nurse's rationalization and excuses are accepted, the more advanced the disease becomes for the nurse. So denial is a symptom of disease, barrier for seeking treatment. Denial is not only part of the nurse with substance use disorder, but also coworkers who work with the nurse. Because of this allows the disease to progress far later into the later stages of addiction, prevented earlier intervention. Most nurses coming in RAMP typically require inpatient treatment because the disease has progressed so far along. In New Jersey, we have the Collins, the good nurse. This was the nurse that killed patients in New Jersey and Pennsylvania. He was terminated, he job hopped, he was in and out of mental health facilities. We have it, it's called the Healthcare Professional Responsibility and Reporting Enhancement Act, passed in 2011. This requires professionals to report to a clearinghouse if they're terminated, if limitations are placed on their practice related to impairment, incompetency, or professional misconduct, if an investigation is ongoing and they quit, whether they know about the investigation or not. And also requires that if someone takes a leave of absence for a physical, mental, emotional, or substance abuse, they're supposed to be reported. We know that in New Jersey, this law was not developed with any nurses' input because we know that many nurses go out for physical reasons, and they really should be reported. The clearinghouse, the notification is done by the entity, the hospital. Also, it states that a professional shall report a colleague if they possess knowledge of misconduct or impairment. So this is that nurses are responsible to report other nurses if they possess knowledge of misconduct or impairment. However, if the nurse agrees to participate in intervention programs, the entity is not required to be reported to the Board of Nursing. They can report directly to the alternative programs, intervention programs such as RAMP. The entity has the responsibility to confirm that the intervention program, that the employee has made contact with the program, and the entity will inform the employee that it will notify the clearinghouse coordinator if they brought a complaint. The hospital has to be informed the nurse that they will report them to the clearinghouse. The entity also is required to submit a report within 7 days of learning of an employee out of compliance, and this is so the nurse doesn't fall through the cracks. Many times employers will follow up with RAMP, and we will tell them the nurse is enrolled in compliance. And we also inform employees if the nurse fails to follow through, then we have the responsibility also to report to the Board of Nursing. So if the hospital is reporting or we're reporting, this is to ensure that the nurse does not fall through the cracks. Other states have very similar reporting laws. And this expires on March of 2016. Hopefully some of it will change. The ANA Code of Ethics Provision 3 states that the nurse promotes, advocates, strives to protect the health, safety, and rights of patients. And in January 2015, the ANA made changes to Provision 3.6. It states that nurses have a duty to take action to protect patients and ensure that impaired individuals receive assistance. They also recommend that nurses approach individuals with substance use disorder problems and mental health with clear, supportive manner, and that we extend care and compassion to the nurse rather than judgment. And also that individuals must identify their own impairment. The number one priority of alternative discipline programs is patient safety. Alternative programs do this through the early detection, treatment, and monitoring of nurses with substance use disorders. Another goal is to decrease the time between identification and entry into treatment. And many do this by providing education to healthcare providers and schools of nursing. The earlier the intervention is with the nurse, the safer it is for the patient. Alternative programs also provide a process for the nurse to recover from substance use disorder through a non-punitive, non-public action. In New Jersey, nurses are given a private letter of agreement, which is a confidential program. They are assigned a number. It's confidential, but it's not anonymous. We do have a board liaison who does know who the nurses are in our program. Peer support provides support, assistance, and advocates for the nurse to remain substance-free and active in the workforce. Currently, there are about 45 to 46 states with alternative discipline programs. And I was in Florida last weekend, and Florida has the first program which started in 1983. There are different types of alternative discipline programs, but there's evidence-based research that indicates that a 5-year program has favorable outcomes, the most favorable. However, in however, in the United States, the programs vary from state to state. Some are 2 years, some are 3, some are 5. And some have different varying requirements, which makes it difficult to really determine what contributes to a successful outcome because of the variation within the program. There are different types of alternative programs. Some are under the Board of Nursing. They're directly under the Board of Nursing. These were created by legislation. They have a separate or private office dedicated staff with alternative discipline programs. These services include assessments, treatment, aftercare, therapy, employment requirements. These are also non-public as long as the participant or nurse is compliant. Another similar type to the first is the under the arm of the board. So this contracts with an organization and delegates the responsibilities to them to monitor the nurse. A third type under the Board of Nursing is a special committee. This model is primarily to protect the public. It's non-public, and the committee enters into agreement with the nurse. This type of program typically does not offer an educational component to the program or to provide primary prevention of substance disorder to nurses. A fourth type of program is the peer assistance program that works in collaboration with the Board of Nursing. In this model, the Board of Nursing and professional associations have a formal contract. And this includes insurance that the public protection and that it is a non-public disclosure. This also provides preservation of the board's powers in regards to the licensure. This type of program offers peer assistance program and has an educational component. They have peer support groups. The board has a staff liaison to work with this type of association. This is a type of program rampant is becoming one. We have a board liaison, and we work closely with the Board of Nursing in New Jersey. A fourth type is peer assistance with no contact with the board. This model provides high protection for the nurse, but there's really not a provision for patient safety. This type is voluntarily, nurses join this. Records are kept confidential, even from the board, and usually there's no communication with the board. And the last type is a peer assistance or EAP with no board relationship. I am actually familiar with this type. I'm not even certain that this type exists today. There is no statutory regulation, authorization, and all the records are private. And just keep in mind that there are, out of all these 6 types of programs, there's variations to each type in each state. So everyone has every state has a little spin on how they run their alternative program or how their programs are run. But the components are similar in the requirements and reports and attendance. The components are similar, but the attendance and reporting may differ from state to state. Most programs require treatment and successful treatment of the 12-step attendance program. That's typically required. Some require initial 90-90, some do not. Some follow are required to do 2 to 3 times a week 12-step attendance at A or NA. And also some include having a sponsor. Models that offer peer support typically have a one-time-a-week mandatory attendance meeting. Some of the programs have nurse-led only peer support groups, while other states have other professionals leading the support groups. Randomized urine testing is required. In New Jersey, we have 25 tests a year. Some do 12, some do 23. We use a variety of panels. We use urine, hair, nail, and blood. All participants in the New Jersey program are tested for alcohol. We are abstinence-based program, so we use a variety of tools depending on the nurse's drug of choice, and then we add some other ones in just to make sure. The monthly reports that we require and other states require include reports by participants, treatment providers, employers, and if needed, pain management. The frequencies of these reports varies from state to state. A return to work process is part of the monitoring in each state, and each state sets up their own return to work policy and restrictions on nurses returning to work. And Al?
Okay, well, thank you. So that's a great overview, Suzanne. Thank you very much. And excellent point about how each state is different, because in the United States, each state is like its own country. So what we wanted to share with you is a real case study. We may get to 2 case studies depending upon the time, but the case study that I'm going to share is a rather complex case study, and we're going to take it in parts. I won't share everything. I will end up sharing everything by the end of the case, but we'll break it up to let Suzanne interject with how people will be treated, because this case comes prior to New Jersey having the RAMP program. So I was a chief nursing officer in an acute care hospital, a community hospital in southern New Jersey. And, you know, we'd be remiss if we didn't think that at times that we don't have people who aren't maybe abusing substances. I always said we probably scratch the surface, you know, of the iceberg. But pharmacy reported to me in the role because I was vice president for patient care services, so I had more departments than nursing. And the head of pharmacy came to me one day, and he said, Al, the Sublimase use has doubled in the OR for the past few months. So my first question was, I said to the director, I said, well, has the practice changed? You know, are we using more Sublimase when we do a case, or has it not changed? And he said, no, there's been no practice change. So my next question was, I mean, I would certainly review the OR statistics quarterly or periodically, but I didn't have them in my head. So I said, has the number of the OR cases doubled? And he said, no, the OR cases are level. We're running about the same as we did a year ago. So then my next comment was, well, I guess you're telling me that you're suspecting someone of abusing the Sublimase. And he said, that's correct. Now, anesthesia, if you've not worked OR, but, you know, they're stocked with narcotics on each of their carts, and they are some of the highest trained professionals. So, of course, my next question to him was, I guess you're surmising most likely that it's probably someone in the anesthesia department. And we were both staffed with, you know, anesthesiologists who were physicians as well as certified registered nurse anesthetist. So he said, that's right. So I said to him, have you gone through their narcotic records? Do you have any clue who it is? And he said, no. So what we could do in New Jersey was we could call really the Board of Nursing. We actually had a separate line to investigators that would come down to try to see if they could find out who was diverting the drugs. And they actually, the whole board, as all the professional boards in any state, has an attorney general, and that was the office they came out of. So I called to request an investigator to come down, because I thought, if we have someone in anesthesia who's, you know, abusing a medication like Sublimase, you know, that could be very dangerous to patient care. So they sent down the investigator who I had worked with previously, and we were on a first-name basis, and we worked very well together, and he was an excellent investigator. The guy was like a bloodhound. So it didn't take him long, and he told me he thought he knew who it was, but he wanted to give it a few more days. And as with anyone who has a substance use disorder, as they get more immersed into their, you know, disease, they become sloppy with what they do. So it was Memorial Day weekend. You know, we just had that here, what, a week ago. It was Memorial Day weekend. So the OR was shut on that Monday. It was a holiday. It was only open for emergency cases, no elective cases. And of course, the investigator was off, you know, for the long weekend, and he came back on Tuesday. And he had checked in the OB unit to see, and the OR as well, to look at the log records for signing out Sublimase. And in the OB unit, there were 3 patients in the anesthesia log who had been documented that they had had Sublimase for cesarean sections. The only problem was there were no cesarean sections done that weekend. So that kind of put the nail into the coffin, so to speak, because the person who he was suspecting, that kind of sealed that he was 100% sure that this was the individual who was diverting and probably using the Sublimase. So he came to me and he said, you know, I think we've got the culprit, so to speak. And he said, what we'd like to do is a confrontation. So we will come down tomorrow. I will have another investigator with me. And he said, advised me that my role would be to call him down. This was actually a male nurse anesthetist, and my role was to get him down to my office, that I wanted to see him, and then the investigators would be there, and I would advise him that, you know, these are the people from the state, and, you know, they would introduce themselves, and I would tell them that they wanted to talk to him, and I would have to leave. And that's how the case proceeded. And we called him down the following day. This was probably about maybe 2 or 2:30 in the afternoon. And the nurse anesthetist came down, and the two investigators then took over. And then I had to go do other things. I couldn't be, you know, in the office or part of that. Now, what kind of struck me looking back at that, it really took a long time. I had been involved in other cases like this where it didn't take nearly as long, but it was well over 2 hours. And then finally, one of the investigators came out and went to my assistant and, you know, said to get me, and I came over, and he came out of my office, and he said, well, he said he did admit to, you know, abusing supplements, and he said it took us about 2 hours to get him to admit it, but he finally did admit it. And he said he's been using an unbelievable amount. And what this nurse anesthetist was doing, the operating room was on the 3rd floor. He was going down between cases into the men's room on the 2nd floor and was injecting himself with supplements because he was so dependent on it, and then would go back upstairs and would administer anesthesia to patients. And I remember when I went into the room, he said, you can come in and talk to him. And I remember when I saw him, he had gotten extremely, extremely thin compared to when I had last seen him, did not look well, and of course he was in tears. Now, one of the things that happened, because we did not have a peer assistance program at that time, was that he would lose his license in our state for a 3-year time period. And this nurse anesthetist was married. His wife was a nurse who was employed at a different hospital who worked the evening shift. So this gentleman would be home with his 3 children in the evening while his wife worked. And of course he was going to lose his license to practice as a nurse and as a nurse anesthetist in the state for a 3-year time period. So, and that's where I'm going to end right now. I will come back. There's more to this case. It's a fascinating case. It's got many facets to it. But I want to stop here for a little discussion because I really think that's what we should do with case studies. And I'm going to ask Suzanne to chime in. How would the treatment differ today with the RAMP program compared to what happened to this gentleman back prior to that program before New Jersey adopted a peer assistance program?
Okay, so we're an alternative discipline program. So what would happen was the DAG would not have been called. They did not get involved. The investigator would not have been called. Your hospital were called RAMP. We would have had the nurse come into treatment. We would have given them a private letter of agreement. They would not receive a public action on their license. They would not lose their license for 3 years. They would be asked to inactivate the license while they're in treatment. And once they successfully complete treatment, you know, inpatient, outpatient, complete, you know, their trust meetings, and they do a return to work process, they would be back to work probably within a year or less, easily.
Which is really wonderful to hear because, you know, as executives, obviously we had to take action. We're responsible for patient care. But what broke my heart as a peer to him and as a fellow nurse, you know, nurses with substance use disorders have impaired practices, but they have a chronic illness like anything else. And prior to the RAMP program coming into New Jersey, they were really criminalized, which was terrible.
Right. So, and Al, what else we would do when we talk to the employer, we strongly encourage them not to terminate. We ask them to, you know, allow the nurse to go into treatment, receive disability, and keep their insurance.
Okay. Very good. Very good. Okay. And I think that's, you know, what's so different today than how it was, where we've really come to really be much more humanistic, and if we're the caring profession, we certainly should be caring for each other. I'm such a strong proponent of that. And technically, as I think we all know, when you do divert things, you could actually report the nurse for theft. But again, I know myself as an administrator would never do that, because I really didn't want the nurse to have a criminal charge, because it was their disease that we really needed to focus on.
Well, it used to be, Al, you're right, they used to be handcuffed and taken away from the hospital and handcuffed. They would call the police.
Yep, it was awful. So now he was not handcuffed or anything like that. The investigator, as I ended the story a little bit ago, said, that I could talk to him for a few minutes. So I went into the office, and of course the investigators were there, and he was crying, and I just have myself, I always relate to what's going on with the other person, or I try to, and he was crying, and I could understand why, and I put myself in his position, and I thought, gee, if this was me, and I knew I was going to lose my license to practice for 3 years, besides the shame and stigma, although it shouldn't exist, we know that it does, I don't know, I just, for some reason, the words came out of my mouth, and I said to him, would you harm yourself? Are you thinking of harming yourself? And I may have even been more blunt and said, would you consider suicide? And he said, yes. And I said, how would you do it? And he said, with a gun, I'd shoot myself. And the next words out of my mouth were, do you have a gun at home? And he said, yes. And I said, oh. And I went out to the investigator, and I said, I cannot let this guy go home. I mean, I'm afraid we'll find him dead, because he's at a low point right now, and I can certainly understand that. Now, this was at the end of the day. It's now about 5 o'clock. The area where I lived, and we're going back a few years, didn't have a lot of psychiatric services at the time. Could not get him into a psychiatric mental health bed in the area. There was none around. So we ended up admitting him to we had a 5-day detox program, short stay, and then patients would be transferred out to a longer-term rehabilitation facility. So I had him admitted to our detox unit, because I thought at least he'll be safe. They will continue to assess him for suicide ideation. We can get a psych consult. He can have care. I can't let him go home. That was my biggest thought. I can't let him go home. And that's what happened. He was admitted to the detox unit. The next day, of course, we had to advise his wife. He allowed us to call his wife, and we had to advise her what was going on. The next day, his wife brings in these boxes of needles and syringes and everything that he had actually, stolen from the operating room. And, I thanked her for, bringing that in. Again, I would not press charges against him. I didn't feel that was the ethical thing to do. And then it was that Friday, the physician from the unit called me. It was around noontime, and he said he would like to see you. He's doing very well, and he wants to say something to you. And he said, I'm giving you permission to come up and speak with him. And I said, fine. So I went up to the detox unit, and he looked far better than the evening that this had happened, when he was confronted and all. His color was good. He was smiling. I shook his hand, and he said, Al, I want to thank you. He said, you saved my life. And I said to him, I said, I know it's a bittersweet thank you, because I said I really felt terrible having to even call someone in, but I didn't know who was doing it, and we had to do it. And I said, I'm really amazed that you are still alive with the amount you're using, and I think, yes, you would have had harm come to yourself if you continued to do what you were doing. So I'm thankful that you're getting the treatment that you need. And it was really a great conversation. He shook my hand, and I felt more at peace, because I really felt bad about the whole thing. We just feel that way. So I thought everything was great. I felt really good about everything. That evening, around 8:30, I got a call from the house nursing supervisor, and this woman, who we still keep in contact today, She had been in the DOM position that reported to me, and then she decided she wanted to work evening shift, and she took the house supervisor's job. And she's a brilliant woman, but also with a lot of common sense, because women always have much greater intuition and common sense than most men do. At least that's my belief, or at least I can say that about myself. And she gave me this call, and in the group room where they had group sessions, we had a security camera that monitored the room. And one of the LPNs who was on the unit would sit at the nurse's station and was watching the monitor as, you know, a group session was going on with the counselor. And we could hold up to 18 patients on the unit, and there were 18 patients admitted on that unit. It was usually filled, and she counted heads, and there was one head missing. And then she quickly figured out it was our nurse anesthetist. So she called the house supervisor, and the house supervisor brilliantly got security, and for some reason her intuition told her, go to the OR, that's what he knows best. And they went into the operating room, and he was in the anesthesia office ready to inject himself with a syringe full of sodium pentothal, which would have killed him. And so she basically saved his life. Of course, then we were able to get him into a psych facility after that, and to our knowledge, he did very well following treatment, but she really saved his life. So I always said it's a great story. Don't admit people to their familiar surroundings, but we really had no choice, because the only alternative we had that evening would have been to have sent him home, where I think he would have committed suicide. And all his suicide assessments throughout his stay, where he was denying it, he had accepted the fact of what he had done. He was glad to be in treatment. He was going through detox. And then I really, when I reflect back on that Friday, feel that, why he wanted to make his peace with me and why he looked so well is I think he had his plan intact at that point. So that was the case, and of course I think the outcome today would be much, much different, because he wouldn't have lost his license. He would have been in a peer assistance program. He would have gone to treatment as he did. He would have gone to the 12-step meetings, to the intensive outpatient program, and the whole continuum of care. But he also would have been re-entered into the workforce at some point, and probably would not bear the embarrassment or the shame that some people have to bear as a professional. So that is one case. I have others, but I thought, I don't know if Suzanne has any comments she wants to make, and then maybe we could open it up for some questions and answers and see where that brings us.
Just about the suicide out, that is a concern for nurses when they get caught diverting. That's a huge concern for us when they call us, that we are concerned that nurses will. And nurses will tell you, I had a nurse the other day tell me she had access to a gun. When she got caught, she just graduated about 5 years ago. She said when she left the hospital, her husband was a cop, she had access to a gun, and she thought this may be the way out versus admitting that she had been diverting. So it's real.
Yes, it is. It's very real. And I know, practicing in a residential addictions treatment center where I practice on weekends, I am constantly, whenever I do an H&P, even though they've been assessed by others, I raise that issue, and not that you can always prevent it. I mean, you have to go by what the people tell you and what you see objectively, but it certainly is a concern. So I totally agree with that. So if you do have any questions, you're welcome to type them into the text message there. And while you're typing, I will share another case that's a little shorter. Suzanne and I also discussed this one. And this one, the treatment would be a little different because it involves another entity. So, same hospital, same role, chief nursing officer. A couple years later, the OB nurse manager comes to me and says, we're missing reels of Percocet off of the OB unit. And I said, okay, so it sounds to me like someone is diverting. So Again, I called the head of pharmacy. Could you check the records? There's reels of Percocet missing off of the OB unit. Do you think you could find out who's doing this? And he went through all the records and he said, I really can't be certain. No one really flags out. So again, back then we called our investigator down. And this time they sent a different investigator who was also, we got along well, but he wasn't to me the crackerjack that the other guy was. And so he had been in there for a couple weeks investigating, and I said to him, I said, I don't know why, but I think it's this nurse. It's just my gut telling me. Because one thing working in nursing now over 40 years has taught me is intuition. And I said, my gut tells me it's this nurse. And he said, I think you're right. I said, well, when would you confront her? And he said, well, I'm only 95% sure. I have to be 100% sure. And I said, well, that sounds right to me. So this nurse ended up admitted with abdominal pain, and it's really a time when managed care worked correctly in that she had a surgical consult, and they were recommending a excision of her gallbladder. And the physician at the managed care plan denied the procedure and said he didn't have enough evidence that she really needed gallbladder surgery. So I guess because the procedure was delayed, I guess she thought maybe people were onto her, and so she fessed up that she had been abusing Percocet. Her medical physician called our addictionologist who saw her. This was over a weekend, got her into a treatment center. So when I came in Monday, the staff reported to me what had happened and that she was now in treatment, which was good because, of course, substance use disorders are covered under the American Disabilities Act, and, you know, she would be covered where she wouldn't lose her license because she was in treatment. So I felt very good about that. So she went through a 28-day treatment program at that time. She then went to, I guess, a month-long, 6-week intensive outpatient program. She was attending groups. And about 2 to 3 months after, you know, the whole thing started, she returned to work. She was a day shift nurse. So we left her on the OB unit, but she could not dispense narcotics. The manager knew what was going on, and I had to fill out quarterly monitoring reports to the board. Because, of course, that Monday when I came in, I called the investigator and told them what had happened. So now she has to be monitored for a certain number of years by the Board of Nursing, and I had to do quarterly reports. And she was doing extremely well in our facility. The reports were glowing. She was doing great. We had no problems. We were about 8 months into her recovery. And on a Friday afternoon, about 4 o'clock, I got a call from a pharmacy in a town across the bay from where our hospital was located. And the pharmacist said that he just had one of my nurses arrested. And I said, who did you have arrested and for what? Well, to make a long story short, what had happened, she had floated prescriptions that she had written out for Percocet to several pharmacies in this town, and a very astute pharmacist thought something looked wrong, and he called the other pharmacies, and they all said that they had gotten a script, so he ended up calling the police and having her arrested. What we found out subsequently to that, she had been moonlighting one evening a week in one of our gynecologists' offices, and she had lifted her prescription pad and was writing scripts for herself. So, of course, now this time she did lose her license because she was arrested, and I will throw that to Suzanne. The difference in this case, would the RAMP program be involved? What would happen?
Right. Okay. So because she had prescription fraud, anytime prescription fraud or patient harm or patient neglect, nurses are giving a public order of discipline. They can participate in RAMP. And get their license back, but they will be publicly sanctioned. There'll be a public action.
Okay, thank you. So in that case, that's exactly what happened. She lost her license because of, being arrested with a criminal, with a criminal.
But with RAMP, she'll lose her license of a public action. Nurses with discipline can enter RAMP. But once they can complete RAMP, they can receive their license back.
That's great to hear.
So it's
Okay.
not a permanent loss. It doesn't
Right,
necessarily mean
exactly.
a permanent.
Yep, exactly. Great. Now, we do have a question. It says, how close is the NJ Board of Nursing to mandating a minimal education requirement regarding addiction for licensure and registration of licenses? And I'll let Suzanne comment too. Go ahead, Suzanne.
Go ahead. No, go ahead. To my knowledge, they're not there yet.
Yep, that's what I was going to say. To my knowledge, for the staff nurse, and by staff nurse, be it administrator, whoever, the RN license, they're not there yet. For the advanced practice nurse, our legislation took effect in 1994, where nurses in New Jersey were recognized as APNs. We recognize clinical nurse specialists, your nurse practitioners, and now actually the CRNAs also come under the Board of Nursing. Initially in 94, we could prescribe all substances in collaboration with a physician, but not controlled substances. Then in 1999, we got the legislation amended, and there was a physician who was on the Senate committee, and he put in the fear that nurses will addict patients if we have narcotic privileges. And so what happened was in 99, what got passed, an APN, an advanced practice nurse, could write a prescription for a narcotic if it was a reorder. Can only be an initial order if the patient was determined that they would die within a year, like if they were terminal, had a bad disease. So at least that got us a CDS license in New Jersey and a DEA license. And then in 2004, we got full prescriptive practice for narcotics, but the caveat was we had to complete a 6-hour program in substance use disorders approved by the Board of Nursing before we could implement that prescriptive practice. So the one place where it has been mandated since 2004 is if you're an APN, it's a one-time thing that you have to do. It's a 6-hour program on substance abuse and substance use disorders approved by the Board of Nursing.
There was a question I saw that somebody asked how many males are in RAMP. We have 19% of our participants are males.
Here's another question. What can be done in nursing education settings to start education about substance use disorders among nurses with nursing students? Are you aware of established curricula to be used to improve education with nursing students? That's a great topic because a lot of your curriculum in the undergraduate program and a lot of your boards don't really require that you include substance abuse education. But a lot of professors do. And I know, for example, at Drexel in our undergraduate program, we actually have one of our colleagues at INSA who presents like at least a half-day, all-day program on substance use disorders in every class in the psych mental health nursing course. Certainly, like myself, even at the graduate level and teaching at the doctoral level, I've actually had a lot of DMP projects, a couple this year, that focused on substance abuse and substance use disorders. So I think you're starting to see it interwoven. NIAAA with alcoholism had developed a curriculum, which I don't believe it ever really took off the ground, but that was for undergraduate education. So I think you're starting to see it move towards that, and I agree, we definitely have got to do that.
Somebody asked how many nurses are on RAMP. There's 145,000 nurses in New Jersey, and we have 508 nurses enrolled in RAMP.
Okay. How do you handle it if the pharmacy insists on turning the RN for theft before you have the opportunity to investigate and turn it over to the peer support system through the Board of Nursing? From my experience, if it was like the hospital pharmacy, or whatnot, we would work together before they would report. I mean, it would be a collaborative effort. Now, if it's a pharmacy outside, like in the case I gave you, that person had already called the police. I mean, it was a done deal before he called me.
We have physicians that call RAMP who have done some checks on their nurses getting prescriptions, and they call us, and they don't call the police. They just call us.
They call you. Okay, great.
Mm-hmm.
Okay, here's a question, Suzanne. Concerned about confronting a suspected colleague, as the ANA Code of Ethics states, wouldn't it be better to report for proper and safe handling?
He or she needs to be reporting. I mean,
right.
You could report that way, but you're not helping the nurse. She needs an intervention. He or she needs treatment.
Right. And I think what you have to do, I think you have to really, I've seen this too, where a nurse, like on a nursing unit, will be diverting drugs, and another nurse knows it's going on, but they just turn their eyes. They don't want to report the nurse, like, to supervisor or anything. Right. That's not helping the nurse nor the patient. So I think that's really important that we do that.
And Al, too, many nurses in ramp, when they get caught diverting, I mean, of course there's some who will deny, but there's quite a few that are relieved that they will confront it. It's over. They're happy that they, it was easy for them to confront them, than to admit it themselves.
Mm-hmm. Okay. And then just a little closure, and then we'll just recheck to see if there are any more questions. But, going back to our nurse anesthetist that I had, I told you he dramatically looked differently. Now this guy had a miserable attitude. He was always that way. He was the type of guy that was, like, always grumpy, always miserable, and this was for years. I mean, people just, like, didn't like to interact with him because that's just how he was. And of course, everyone always thought it was his home life or whatever. We didn't go into it. And so after, of course, he was confronted and what happened, of course, I knew the OR staff had to know what was going on because they knew he wasn't back. Of course, we didn't share anything, but people have contacts in a community hospital. So, I thought it was a time to do some education with the operating room staff. And I went up, and one of the questions I said to them, I said, didn't you notice any physical changes in him? Because he's gotten so thin, he really looked ill. And the response was, and I think it's a great, great learning thing, they said to me, even though he was married, and even though he has 3 kids, he's a male nurse, so we just assumed he had AIDS, and we just didn't want to address it. And I said, you can't stereotype people like that. So it's amazing what people do to avoid confrontation or to see what's going on. And I think one of the things we really need to spell when we talk ethics and everything is that we shouldn't be stereotyping people. And I think that's a very, very big learning point. Okay, if there, I don't see any other questions. Oh, here's a question.
More.
There is another one for how helpful are support groups.
Right. How helpful are nurse support groups?
We find them very helpful for the nurses. It really instills hope and strength. For nurses to come in, there's a lot of shame and guilt. So when they come into a room with other nurses, shame and guilt gets diminished. I mean, they feel that they can say that they actually diverted. Nowhere else can they go into. They can't go to a 12-step meeting and say, "Oh, I diverted. I'm your nurse and I stole from patients." They can say in front of other nurses because other nurses have done it. They can see other nurses going back to work. They network. They find out where jobs, where they can find jobs at. We help them, find jobs. We have a lot of ramp-friendly nurse employers. So it's very supportive for the nurses to be in the support group.
Well, it is 8:30, so we've been here an hour. We would like to thank you for your participation. Suzanne, I thank you very much for an excellent presentation. Robert Ranieri, our Executive Director at the International Nurses Society on Addictions, we appreciate his help in coordinating this and making it all work. We couldn't do it without him. And we thank you for your support and your attendance. Look forward to other webinars. We will be doing more, probably another one later in the summer or early fall on another topic related to opioid dependency. So stay tuned for that. This will be posted on our webinar for people who would like to listen to it. and it also will be posted at the American Academy of Addiction Psychiatry website at the PCSSO website as well for anyone who wants to listen to it. So have a wonderful evening, have a wonderful summer, and thank you again for attending.
And we'll post we'll put answers to all these questions online when we get them all tallied and answered properly.
Okay.
All right. Thanks, everyone.